Alright, number 9 on the list, constipation. When I say to you constipation, from here on in, I want you to say the 3 F's. This is one of the few times where you can actually say the F word and not get in trouble for it. So the F word that I want you to know now is fluid, fiber, fitness. Those are the 3 things that happen with those are the 3 treatments of constipation. Fluid, fiber, fitness. You need to increase that person's fluid by, they need to drink 2 to 3 liters of fluid a day and at least 1 warm cup of fluid in the morning time. Fitness, increase their exercise. If they have a sedentary lifestyle, they need to become more active, because the more active they are, the more it helps to increase peristalsis. And then fiber. They need to add fiber in their diet. Fresh fruits, vegetables, that type of thing. And then you need to teach your patient to sit on the toilet the same time every day to kind of train their bowels of a time to, that this is the time to poop. And if they do it every day, then eventually their body's going to get used to it and know that, hey, at this time of the day is the time that I poop. And then the other thing that you want to do is teach your patients not to ignore the urge to poop. Sometimes people feel like they have to poop, but they're out in public, they don't want to, or they feel like they have the urge to poop, and ooh, that is gross, I don't want to do it now, or whatever the case may be, it's inconvenient, I'm embarrassed, whatever. But as soon as they feel the urge to poop, they actually need to go and do it and not try and stifle it. So that, my friends, is constipation. Then you have the other side of constipation, which is diarrhea. And so constipation occurs when peristalsis is slow and too much water gets absorbed in the large intestines. Diarrhea is just the opposite problem, where peristalsis is it's hyperperistalsis, and too much, not enough water gets absorbed in the large intestines, and that person has a large liquidy stool. Most diarrhea is caused by, most acute diarrhea, other than medication, caused by medication. The other type of diarrhea is caused by either E. coli, C. diff, Salmonella, Giardia, and there was another one in your book that I don't remember at this moment. But they're usually caused by a parasite or by a bacteria of some kind. And basically what's going to happen is that the patient is going to have to be on some type of antibiotic to kill the bacteria. And once that bacteria is killed, then the normal flora can flourish again, and the diarrhea will right itself. All right. Colostomy, types and care of colostomy. That's actually in chapter 33 towards the end of the chapter. I'm sorry, chapter 34 towards the end of the chapter. And really what they talk about there is they're talking about you can have a colostomy, an ileostomy, or a jejunostomy. You can have, I'm looking at it on page 768. And the first thing it talks about is the ileostomy. And the thing that you need to know about the ileostomy is that with an ileostomy, the end stoma is formed by bringing the ileum up through the surface of the skin. So the ileum is the last part of the small intestines, if you remember, Dow Jones Industrial, duodenum, jejunum, ileosteum. So you have the ileum coming up, and the food is going to go through the duodenum, the jejunum, and then it's going to stop at the ileum, and it's going to come out. So that stool is going to be loose, and it's going to be high in acid content, because it hasn't been absorbed yet, and it still has a lot of liquid in it. Remember, the water gets absorbed through the small intestines. Excuse me, I lied. The water gets absorbed through the large intestines, and so if you have an ileosteum or ileostomy, none of the water has hit the large intestines yet, so it's going to be very liquidy, very acidic. So good skin care is very important with the ileostomy, and remember that when you're putting on ostomies, you want to make sure that there's no more than 1/16 of an inch in between the stoma and the hole that you have to cut into the wafer. And then you want to make sure that you have meticulous skin care when you go to change that wafer out, because that, again, that effluent is very acidic. So any effluent of the small bowel that gets onto the skin is going to be itchy. It's going to cause that skin to itch and break down much more quickly than it would in a colostomy. Okay, so then the second thing that they talk about on page 769 in your book is a colostomy. That colostomy is usually the proximal sigmoid or descending colon is going to be brought up through the surface, and you can have a single barrel or a double barrel stoma, but those are going to be brought up in that stool depending on where it is. If it's descending sigmoid, that patient is actually going to have much more of a formed stool in there, because it will have gone the whole way through the intestines before it comes out into the colostomy bag. And people with descending colonoscopies can actually be trained to go without a bag, because just like you and I, we know that if I eat, then, so many days later or so many hours later, I defecate. So those people can be trained to put the bag on around the time that they defecate, and then defecate, take the bag off, and they can go all day without having a bag on. Anywhere else, though, they're going to end up having to have a bag, because the stools are going to be looser and more uncontrollable because of the amount of water that has not been absorbed yet. Alright, so then ostomy care, we talked about doing meticulous skin care, but you want to just use soap and water. You don't want to use a lot of chemicals around that stoma. You want to make sure that the stoma is pink to beefy red. A pale pink or a light pink is a sign that circulation isn't happening, and then if it's white or gray or black, there's definitely something wrong with the stoma, and you need to either let the RN know or let the doctor know right away. Okay, make sure that you remember the steps and how to change an ostomy bag. I know that you guys have gone over it in class, but just in case you don't remember, look on page 772. It walks you through step 1, cleanse the peristomal area with soap and water, pat it dry. Step 2, you're going to have to cut a hole in the wafer, and make sure that you cut the hole only 1/16 of an inch bigger than the stoma. So you're actually going to have to measure to see how big the stoma is. You cut it, then you remove the tape off the wafer, and you actually put the wafer onto the skin around the stoma area there. Sometimes you need to do a little of adhesive powder or adhesive paste around the peristomal area, just so that wafer sticks better. And then you want to smooth out the wafer to make sure that there's no pockets or no air in there, because if there's a pocket of air, that means that the stool can seep down inside, and you could actually cause serious wounds on your patient from where that stool has sat underneath that wafer. Because the wafer doesn't get changed except for, maybe once every 7 days, unless there's a need to change it earlier. But once every 7 days, if there's stool under there that you didn't catch, that's enough time for that to cause irritation. I'm not trying to be gross, but just think about it. Those times where you've gone to the bathroom and maybe you didn't wipe, and hopefully this was when you were younger, and your bottom itched all the time, and then you went back in there and you cleaned yourself better, you're like, oh, wow, okay. Well, that's what happens to that patient's skin, is that their skin starts to itch and then they starts to break down because of the stool that's left underneath it. So meticulous skin care is very important for people that have ostomies. Alright, and then when you actually go to put the bag onto the ostomy, if it's a 2-piece appliance set, make sure it's like a Ziploc. So make sure that you take your thumbs and you go around the seal, and you make sure that every part of the bag is sealed on there tightly and correctly. And then make sure too that the bag has the clip onto it, that you've turned the clip over and you've fastened the clip. Otherwise, you're going to have a nice, pretty colostomy, and you're going to have done all that work and changed the bag, and then the poop is going to come right out of the bottom of the bag because you forgot to seal it. So those are some things that you don't want to happen. So that takes us through constipation, colostomy, and diarrhea. Now I want to talk about appendicitis. Appendicitis is inflammation of the appendix, and the appendix is a little variform that's on the bottom of your colon. And at one time, it was thought that the appendix didn't do anything, but now science tells us that the appendix actually does help us with absorption some. So if you're interested, just do some research on Google and you can actually see specifically how scientists are saying that the appendix is helping us. But what will happen with appendix? The person will have a fever. The person will have rebound tenderness in the right lower quadrant. That's a key sign. A key sign is rebound tenderness in the right lower quadrant. What I mean by rebound tenderness is this. You go to push it in, it doesn't hurt that patient. But when you let go and you let go of your hand, the tenderness or the pain is going to come when you let go of your hand. Or when they go over bumps, or when they jump up and down. That's going to cause tenderness in that right lower quadrant. And that right lower quadrant where the appendix is called McBurney's point. And that's what you're going to see on the test, or you have the possibility of seeing on the test, is McBurney's point. And that's what you need to associate from now until you get finished with nursing school, that McBurney's point and appendicitis and rebound tenderness all go together. There's going to be rebound tenderness at McBurney's point, which is the right lower quadrant. Nausea, vomiting, fever. So what's going to happen then is they're going to do an ultrasound of the appendix. They're going to do a CT scan. If it shows that there's inflammation there, then they'll go in and they'll do an appendectomy, where they actually go in and remove it. Now, nowadays they can do an appendectomy laparoscopically, where they make 3 little incisions and they go in and snip it off and remove it through, just like it looks like a little joystick or a little tube. Really, it's a tiny tube, tinier than my pinky finger, tiny tube that goes in, and it has little clippers at the end, and the doctor uses like a little joystick to manipulate it, goes in there, clips the appendix, takes it out, and the person is left with just 3 little laparoscopic incisions. And usually they don't even have sutures or anything. They just have skin glue over those little incision marks, and it heals up and the person can go home the next day. Now, if the patient waits too long and the appendix ruptures, now you're talking about a whole new level, and now that person is going to develop peritonitis, where all of the contents of the appendix, which remember it's attached to the colon, so now all the contents of the colon, all the contents of the appendix is ruptured and is in the peritoneal cavity, and that's going to cause serious risk of sepsis, because now in a sterile environment, you've got all kinds of feces and all kinds of germs that are just fine when they are left in the colon, but when they get into the peritoneal area, it causes serious damage. So that patient is going to be on powerful antibiotics like vancomycin, gentamicin. They're going to go in and they're going to have to actually clean out the peritoneal cavity, which is a major surgery. So now instead of coming in for a laparoscopic surgery and going home the next day, they're going to be in the hospital for at least a good 3 to 5 days, and probably even longer than that, depending on how long it takes to clear up the infection. Number 13 on the list talks about diverticulosis. Diverticulosis is a condition where your large intestines grows little outpooches on them. So if you think of your large intestines as looking like a sausage, then on the outside of the sausage, there's little pouches that are sticking out from them. And what will happen is, normally, if things are moving, if peristalsis is moving normally, then the poop doesn't have time to collect in those little outpooches. But sometimes peristalsis slows down, and poop or seeds like from a strawberry or a raspberry or even popcorn seeds will get caught up into the little diverticulosis or that little outpooching and cause inflammation. That's when diverticulosis turns into diverticulitis. Diverticulitis is an acute condition, whereas diverticulosis is a chronic condition. Somebody can have diverticulosis but not have diverticulitis. Diverticulosis is just having a colon that has outpooches on there. Diverticulitis is when those outpooches get inflamed and get infected. Usually then that person is kept NPO, is given an antibiotic, and is given some kind of laxative to help get rid of those the poop that's in that little diverticula or that little outpooching. And then after the inflammation has gone away, the pain subsides, and that person is put back on a regular diet. And actually, they're going to be put back on a low roughage diet, meaning they don't eat a lot of vegetables, because the vegetables will get actually caught up. All that fiber bulks up the stools, and then that's what causes it to get caught in those outpooches. So they don't want thick, bulky stools, kind of just the opposite of what we want to do with diarrhea, and the opposite of what we want to do with constipation. We want a low residue diet so that that person eats and it comes right out. We don't want it to be liquid, but we don't want it to be really formed either, because the more formed it is, the more chance of it getting stuck in those outpooches on the sides of the colon. So I don't know if that makes sense to you. Hopefully it does. Okay, Crohn's disease. Crohn's disease is a immune disease of the colon, and what usually happens with that is that you have it's an inflammation of the colon, and you have ulcers. Give me just a second to turn to it in the book so that I can make sure that I'm talking to you about the right things. Okay, so we're on page 751 in the book, and Crohn's disease is inflammatory bowel disease, IBD, and it can involve any part of the GI tract, but most commonly it affects the terminal portion of the ileum. Okay, so remember, it's Dow Jones Industrial, so it's gonna that's the third portion of the small intestines, right before it gets to the large intestines. All right. And so sometimes what happens is that that ileum, the distal portion of the ileum, gets inflamed, and that inflammation extends through the intestinal mucosa, which can cause an abscess, fistulas, or fissures. Fistula is an abnormal opening, so it would be like an abnormal opening between the ileum and the peritoneal cavity, or the ileum and the colon, the large intestines. Abscesses, you know what those are, and then fissures are unnatural tracts or ulcers that it can cause. And so this Crohn's disease causes people to have bouts of diarrhea and then bouts of constipation. They get a crampy abdominal pain, weight loss, fever, and diarrhea occur. The cramping pains usually happen after eating, and so what ends up happening is people with Crohn's disease just don't want to eat, because they know as soon as they eat they're going to get this cramping pain. So as a result, they oftentimes lose weight. And even more important, that inflammation, just like with appendicitis, if you don't catch that inflammation, it can actually perforate, and now instead of having Crohn's disease, you've got peritonitis. So it's really important with any of these inflammatory diseases that you catch it before it perforates and causes an even bigger deal with peritonitis. So again, the complications that arise from Crohn's disease is fissures, abscesses, strictures, or fistulas. And fistulas usually occur between the colon and the vagina. So what will happen is ladies will actually start to poop out of their vagina because of the abnormal opening with the abnormal fistula that happens because of Crohn's disease. So that requires surgery to repair. It's usually going to require a colostomy of some kind. So it's really important that if our patient has Crohn's disease, that we teach them to watch out for the inflammation. And what are we going to do? First of all, how is the doctor going to know that? Well, the patient's probably going to be anemic because absorption is going to be a problem. So that's going to be one of the first signs that maybe something's wrong. So a CBC is going to show that. But then the doctor's going to do an endoscopy. Usually they'll do a colonoscopy or a sigmoidoscopy, and they're going to do some biopsies to make sure that we're taught what we're talking about. We want to make sure that we don't have colon cancer going on. Then the actual therapeutic piece of this, the measures that we take are going to be aimed at the symptoms, okay? And we're going to, we want the Crohn's disease to go into remission. So if you look in your book on page 753, there's a table there that talks about the different medications that are used with Crohn's disease and the different things that they do. So make sure that you just go over that chart and you're familiar with some of those medicines that are there. Alright. Moving along on your list. Bowel obstruction, small bowel obstruction. Alright. So small bowel obstruction is just that. It's an obstruction in the small bowels. So what's going to happen with a small bowel obstruction is, number one, that person isn't going to be able to poop. And so they're going to get full. They're going to be nauseous, because remember, what goes in has to come out. If there's a blockage at the bottom and it's not coming out of your anus, then it's going to start to come out of your mouth, because there's only two ways in. Your anus or your mouth. And if it comes in your mouth and it's not going out of your anus, it's going to eventually back up and come back out of your mouth. So these people are going to be very sick, because poop, literally is going to start to back up into their stomach, and it's going to be painful. It's going to cause, and eventually it'll back up all the way into their esophagus, or they'll start to throw up poop. So what will usually end up happening is that patient's going to be NPO. They're going to drop an NG tube down to suction out all of that contents of the stomach, and usually that content is brown because it's poop. So it's going to be brown, maybe greenish brown, and I know it's going to sound gross for you guys that drink that naked juice, but there's a juice, like I think it's kiwi juice, that's kind of a brownish green color, and that's exactly what the contents of the stomach looks like for somebody with a small bowel obstruction. It's really just disgusting like that. But that person is going to feel so much better once you drop that NG tube down, because it's going to suction out all of that feces from the stomach, and then the bowel is going to be able to rest because that person isn't going to be putting anything else into their stomach. So usually those two things alone, the NG tube and that patient being placed NPO, will allow the obstruction to work its way out, unless the obstruction is a mass, and in that case surgery is going to be involved, or unless it's caused by intussusception of the bowel. Intussusception of the bowel happens when the bowel telescopes in on itself. So you know how when you look at a telescope, that person takes the telescope out like that, and then they can push it back in, and it's a small device, and then they take it out and they pull it out. That's what's happening with your bowel, is that it spirals in on itself and it causes a blockage. So in intussusception, the doctor is actually going to have to go in there and remove parts of the bowel that have telescoped in on itself. And then depending on the inflammation that's involved and how severe it is, that person may or may not end up with a colostomy. So we have bowel obstruction, intussusception. We talked about ileostomy and treatment and ostomy care. And that concludes chapter 34 in your book. And that concludes 9 through 18 on the Digestive D&D study guide that Miss Stevens gave you.